All right, welcome back to the deep dive. Today we're opening up a file on a topic that's, really complex.
It is. We're talking sinonasal tumors and then the massive challenge of nasal reconstruction.
A true minefield for the boards.
Absolutely. High-stakes pathology and very difficult to reach anatomy.
It really is. And look, before we get started, just a very direct request for you listening.
Yeah.
If these deep dives are helping your revision, please just take a second and rate this show.
It genuinely helps us reach more residents.
It does. And leave a comment. Let us know what you want us to cover next. We do read them.
We do.
And one final thing. This is the core knowledge, but if you want the Journal Club and the Clinical Cases episodes, you have to get the premium subscription. That's where we really dig into the decision-making.
That's where the theory gets tested.
Okay, let's do it. Sinonasal tumors. From an exam perspective, what's the setup? Why is this such a focus?
Well, first, they're rare. Less than 1 per 100,000 people per year.
So you don't see them often.
Exactly. But the anatomy makes them incredibly dangerous. They're tucked away in the maxillary sinus, the ethmoids.
Right next to everything important?
Right next to the orbit and the cranium. It's high-value real estate. A miss here is catastrophic.
Which leads right into presentation. I'm guessing these don't show up early?
Almost never. Delayed presentation is the absolute rule. The early symptoms are, so nonspecific.
Like what? Just a blocked nose?
Unilateral nasal blockage, maybe some blood-stained discharge, anosmia, loss of smell.
So it sounds exactly like chronic sinusitis.
Precisely. And that is the trap. They're often treated for sinusitis for months before anyone thinks. Hang on a minute.
So what are the red flags for us? When do you need to switch your thinking from infection to something more sinister?
It's the late signs, the signs of invasion. You're looking for things like proptosis or diplopia.
So the eye's being pushed.
The eyes being pushed or epiphora, watering eyes from a blocked nasolacrimal duct.
What about nerve involvement?
Huge red flag. If you see trismus, the pterygoid muscles are involved. Pain or paresthesia in the cheek, that's the infraorbital nerve.
V2?
V2. And if you see an oroantral fistula, well, the tumor is eaten through the floor of the sinus.
Okay, so unilateral signs plus any orbital or neuro sign means tumor until proven otherwise.
That's the rule.
Let's get into the pathology itself. It seems like a very mixed bag.
It's a zoo. But if you have to know one, you have to know squamous cell carcinoma, SCC. It's the most common by far.
But not the only one.
Oh, no. You've got adenocarcinoma, always ask about wood dust exposure, olfactory neuroblastoma, malignant melanoma, and adenoid cystic carcinoma.
Which is the one notorious for perineural spread?
The very one.
Okay.
Then you have your sarcomas. Think chondrosarcoma and rhabdomyosarcoma.
I want to pause on the benign tumors because two of them are, well, they're not really benign in their behavior.
You're talking about inverted papilloma and juvenile angiofibroma.
Yes, Echo, why is inverted papilloma such a big deal?
Because it's a wolf in sheep's clothing. It's locally aggressive. It eats away at bone, and this is the key exam point, it has malignant potential.
What's the risk there?
About a 2% risk of transforming into SCC. But maybe more importantly, a well-differentiated SCC can look almost identical to it histologically.
So you need a specialist pathologist.
You absolutely do. And the recurrence rate is high. You have to follow them forever.
And what about the other one? Juvenile angiofibroma. A very specific demographic.
Adolescent males, almost exclusively. A teenage boy with recurrent, really significant epistaxis.
Sure.
This has to be high on your differential.
And the number one rule here,
Yeah.
the thing you must not do.
Do not biopsy it in the clinic. I'll say it again. Do not biopsy it.
Why not?
It's a bag of blood vessels. You will cause a life-threatening torrential hemorrhage. It's a radiological diagnosis. Full stop.
That's crystal clear. So you have a suspected mass. Let's move to the workup. What's step one?
Step one isn't a scan. It's a phone call. You call the skull base MDT. You cannot manage these cases in a silo.
Okay, and for imaging?
You need both. CT for the bony detail to see erosion, and MRI for the soft tissue. It's crucial for telling the difference between tumor and, trapped secretions.
And once you have the tissue, assuming it's not an angiofibroma.
Then excision is the main goal. Clear margins. With malignancies, that's usually followed by adjuvant radiotherapy.
Is there a point where you just can't operate? Contraindications?
Yes, there are limits. If the tumor is wrapping around the internal carotid artery or in the cavernous sinus, or there's just massive intracranial extension,
The morbidity is too high.
the morbidity outweighs any potential benefit. You won't get it all out.
So assuming it is resectable, that leaves a hole, a big one. Let's get into reconstruction. What are the absolute primary aims?
There are 5, and you have to nail all of them. Number 1, dural seal.
No CSF leak.
Game over if you have a CSF leak. Number 2, separate the aerodigestive tract from the intracranial space.
Keep the brain clean.
Exactly. Number 3 is reestablishing the orbital and oropharyngeal cavities function.
So they can see and swallow.
Right. 4 is form skeletal support soft tissue. And 5, obliterate all dead space.
Because dead space just gets infected.
It's an abscess waiting to happen.
Okay, let's talk classification. You have to know Brown's revised classification for the VIVA. Can we walk through it?
Let's do it. Think of it as a ladder of severity. Class 1 is simple, a maxillectomy that doesn't create a neuronasal fistula.
Palate's intact.
Palate's intact. Class 2, you lose the palate, but the orbit's fine. Class 3, you're getting into the orbit, but you save the eye.
Okay.
Class 4, the eye is gone. Exenteration. Class V is a massive orbitomaxillary defect, and Class 6 is a nasomaxillary defect.
So it's just a logical progression of what's been taken.
That's all it is.
Which brings up the big debate. Prosthetic obturator versus flap reconstruction. How do you choose?
It's a trade-off. Prosthetics are good for small defects, and you can take them out to check for recurrence.
Which is a huge advantage.
It is. But for large defects, especially after radiation, they're terrible. They don't fit well, they leak.
So for anything big, we flap.
For big defects, we flap. You bring in living, vascularized tissue. And if there's any dural exposure at the skull base, a flap isn't optional. It's mandatory. You need a multi-layered seal.
Right. Now let's shift focus to the external nose. The principles here are a bit different. It's about layers, isn't it?
It's all about the layers. The trilamellar structure, you have to think in threes.
Okay, what are they?
Layer 1 is the external skin. Layer 2 is the mid-layer, the bone and cartilage that provides support. And layer 3 is the internal lining.
The mucosa.
The mucoperichondrium. And the core principle is you have to replace, like for like, whichever of those 3 layers are missing.
And to do that aesthetically, we use the subunits principle from Burgett and Manek.
Yes. The dorsum, tip, columella, sidewalls, LA, and soft triangles. The rule is if the defect is more than half of a subunit,
replace the whole thing.
Replace the whole subunit. You hide the scars and the natural shadows between them. It tricks the eye.
It's brilliant. Okay,
Yeah.
Let's drill down. Layer 1, skin. What are the options?
It's the reconstructive ladder. Tiny and superficial, you can just close it. Upper 2/3 of the nose, the skin is thin. A full-thickness skin graft can work well.
Preauricular donor site.
Perfect. But the lower third, the tip and allay, that skin is thick, sebaceous. Grafts look like a patch.
So for defects there, even small ones.
Local flaps, bilobed, nasolabial. But for anything over about 1.5 centimeters or anything deep, you bring out the workhorse.
The paramedian forehead flap.
The paramedian forehead flap. It's the best color and texture match you will ever find for nasal skin.
Okay, that's the cover. Now for layer 2, support. Without it, the whole thing just collapses.
It shrink wraps. You have to build a scaffold, and we use cartilage.
From there.
Septal cartilage is great if it's there. Ear-condyl cartilage for curves, or costal cartilage rib if you need real structural strength.
And what are you building with it?
You're building buttresses and braces. A dorsal strut for the bridge, a alar batten grafts to stop the nostrils from collapsing on inspiration.
You're engineering an airway. All right, the final, and maybe hardest layer, the lining. Why is this so difficult?
Because if you get it wrong, the whole reconstruction fails. If you have a raw surface on the inside of your new nose, it heals with scar.
And scar contracts.
And scar contracts. It pulls everything inward, and you get a distorted, blocked up mess.
So what are the options for replacing it?
For small defects, maybe a local hinge-over flap, but they're not very reliable. Much better are intranasal lining flaps, like swinging mucosa over from the septum.
But what if the whole septum is gone as part of the defect?
Then you get creative. You can place a skin graft on the deep surface of your forehead flap before you transfer it, or you can fold the distal end of the forehead flap on itself.
So it provides both the cover and the lining.
The skin provides both. It's a really elegant solution for total nasal reconstruction.
It really is. So to summarize this huge topic, you need a high index of suspicion, an MDT approach, and a clear understanding of what you've resected using a system like Brown's.
And then you rebuild layer by layer.
Yeah.
Skin, support, lining, replace what is missing.
That's the mantra.
It is. But I want to leave you with one final thought to consider.
Go on.
We get very focused on these elegant, multi-stage, technically perfect reconstructions, but we're often dealing with elderly patients with aggressive cancers and maybe a poor prognosis.
Right.
So you have to ask yourself, Is a 3-stage forehead flap that takes months to complete really the best option for this person? Or is a simple obturator, which might be less perfect but gets them home to their family in a week, the more humane choice?
That's a powerful point. It's about treating the patient, not just the hole in their face.
Exactly. Treat the patient, not the defect.
A perfect place to end. Remember, to see how these principles apply in the real world, subscribe to the premium feed for our clinical cases episodes.
It'll be worth your time. Good luck with the boards.
We'll see you next time.